everyone. Good evening. Welcome to one of its kind webinar on artificial intelligence. So the actual topic for today is role of artificial intelligence in present and future pulmonology. Now, this interesting topic is brainchild of our CCI Chairman Trustees Dr. N.S. Krishna and Dr. Narayan Pradeep. I thank them a lot. Our CCI webinar coordinator Dr. Vijay Kumar Chetty, and under the able guidance of Dr. Ashish Dubey, the CCI National President, and Dr. Anil Maske, the CCI National General Secretary, I, Dr. Mehul Thakkar, will be moderating the webinar on artificial intelligence. To help me through this amazing journey that we are going to go through in the next hour or so, I have with me star speakers. Let me start with our guest faculty, Dr. Balu. Dr. Balu PS is the Director, Center for Digital Health and Artificial Intelligence, Research and Training at Basaveshwara Medical College and Hospital, Chitradurga. And he's the Dean in Research, SGM University, Chitradurga. Sir has vast experience in public use of AI in public health, and he'll be guiding us through that. We have an eminent panel with us, including Dr. Anil Kancharla. He is a pulmonologist and critical specialist from Faith Specialty Clinics, Vijayawada. We have with us Dr. Devi Jyoti. She is consultant pulmonologist director at Nivid Chest and Eye Center at Raipur. We have with us Dr. Dinesh. He is the director, Department of Pulmonary Critical Care and Sleep Medicine at HCG Hospital and Bosch Hospital, Bangalore. Dr. Bhagwan Mantri. He is a consultant pulmonologist and a critical care specialist at Mulchan Hospital, New Delhi. And Dr. Rajesh, who is an associate professor in the Department of Pulmonary Medicine at KS Hegde Medical Academy, Mangaluru, Karnataka. So with this eminent panel, let me just kick the ball rolling by telling you what is AI. Artificial intelligence is use of machine learning or use of computers, which as was called as the Turing test. Alan Turing in 1950 was one of the founders of modern computers and artificial intelligence. So what Alan Turing said was that intelligent behavior of a computer is the ability to achieve human level performance in cognition related tasks. Simple as some repetitive task, if you teach the computer to do it, it will do it better. And AI in medicine is now developed into two subtypes, virtual and physical. The virtual part ranges from electronic health record systems with our government of India coming up with AVDM. We have neural network based guidance systems, prediction scores, radiology, or diagnostics in general. And the physical part deals with robots assisting in performing surgeries, intelligent prosthesis for handicapped people, and elderly care. But the major focus of AI has been in imaging. So it's imaging. But as you'll see today, that it is not just imaging, much more than that. And there are certain terms which I need to make clear. We know what is machine learning. We know deep learning, neural network, natural language processing. These are the terms not to be confused with. Machine learning is AI systems' capability to learn from data and improve its performance. Deep learning is a subset of machine learning in which you refer to the capability to learn from an unstructured information, which now the computers are beginning to do. Neural network is, machine learning in which computer learns to perform a specific task using examples. Like say, if I give him thousands of X-rays and I tell them this is how you label them, the neural network will try to form an algorithm. So based on these terms, let's speak about AI. How is it helpful? Currently, the focus of AI is to help in hospitals, drug development, clinical trials, and in the end, enabling precision medicine. Highly repetitive work can be done by machines, which can help doctors to develop the results faster and more accurately. Most importantly, I feel it will augment the professionals as we see to offer better expertise and assistance, and it will reduce the wait times. You know what? WHO, as a strategy for early detection of tuberculosis, did a study which used chest radiograph as a screening tool. But lack of training or lack of pattern recognition in the periphery led to hampering of these efforts. So there came AI to overcome that disability, where pattern learning and pattern recognition helped the doctors or the peripheral health workers identify people at risk or identify the people who may have tuberculosis. A recent multi-center study showed that high-resolution computed tomography, that is the CT scan by using an AI software, was able to provide classification of fibrotic disease, which was able to match human level. So here we are sitting in an era where we as pulmonologists will probably play a central role in diagnostics and in pattern recognition with the help of AI. It cannot replace us, but we have to use it in the way which can help us deliver precision medicine. And to throw some light on the use of AI, let me start upon by calling Dr. Mantri to take over the topic of AI in lung imaging. Dr. Mantri.
Good evening, friends. I am Dr. Bhagwan Mantri. I'm consultant pulmonologist in Mulchand Hospital. And I will talk about AI in radiology. So if you talk about the radiology, I would say this is a quite young branch compared to the, the other branches. Since the inception of X-ray in 1895, more than 125 years ago, the radiology has many advances, and especially in last 3 decades. The radiology has developed advances from the X-ray to we have the PET scan that scan throughout a body in a few minutes. And at the same time, it is not only the advancement, we are able to detect the functionality and the physiology of the images. And the next step in this is what comes as artificial intelligence. So what is artificial intelligence? The artificial intelligence is a very simple thing that in a simple way, what we can see that we are making our computer like a human intelligence. The machine learning is further a subset of artificial intelligence where the machine uses some algorithm that the performance improves with the exposure to more and more data. And the further, the subset of this machine learning is a deep learning, where the machine uses the neural network and over the time further learns and gives the best result. So these are the technique that we use in the imaging, and this is a convolutional neural network. It's a very important technique that we use in the AI for the image. So my topic today is a use of AI in radiology, but since this is a CCI platform, I would focus mainly on a thoracic radiology. So there are mainly two ways for the AI in radiology. That is a programming an algorithm with a predefined criteria that is supplied by the experienced radiologist, and also letting an algorithm that is learned from a large volume of data, either supervised or unsupervised, but uses this algorithm, extract the specific pattern, and then can come up with the insight that escape the human eye. And we need to understand that over the time, they further can become intelligent. So artificial intelligence in chest X-ray imaging, I would focus mainly on the thoracic imaging. So first we come to the X-ray reading. The first application of artificial intelligence is a workflow optimization. It detects simply by a very simple technique. The AI in X-ray is actually based on a texture-based feature, density-based feature, or whatever the feature that what we are giving through the radiologist or interpreting the chest examination. But what we came to know that even this simple technique has reduced this turnaround time by 44%. And this has a specific role, in all kind of a pneumonia and tuberculosis, like this traditional machine learning app used with the texture and the focal and the shape abnormality feature and gives a significant diagnosis of tuberculosis. This is a study that done by Wang et al. In 2019. And what they found that this solution outperformed physicians, including the thoracic radiologists, in detection of a tuberculosis. And this is a study of 2019. In last 3 years, we have come up with very fine diagnosis and the results. The role is also there in pneumonia with the same technique, including such as computer-aided solution, as well as the deep learning and the radiomics, further aid the diagnosis of pneumonia. This is a paper that produced by Rajkumar et al. In 2017, developed a deep learning algorithm for a pneumonia detection, and they also found that they performed better than the average radiologist, though not better than the best radiologist. So the role of AI is also there in a lung nodule. They include the CAD for detection and the CAD for characterization. So AI detect not only that whether the nodule is there or not, it also helps to detect about the malignancy. And this detection of the malignancy has been produced by a famous paper in which more than 40,000 chest radiograms were studied. And surprisingly, what we have come to know that they developed the algorithm was higher. The validated data set was higher than 17 out of 18 physicians. And even these physicians shown some improvement, once they are using the second reader. Artificial intelligence has also a role in chest CT, even though the X-ray had shown significant improvement and fundamenting results about the the diagnosis and the interpretation and the sensitivity and the specificity. But the CT nowadays also helping a lot as far as the AI is concerned. In the AI, there are a lot of commercially available computer-aided packages are available with many companies, including the Siemens and the General Electric. But specifically for the lung nodule, this is a study where the lung CAD algorithm was used from the Siemens. This was available since 2006. And what they came to know that the sensitivity of the lung nodule detection was 78.1% for a doubling reading, and around 97% for the CAD at an average cost of a 3.7 false positive detection. Even though this study found very specific for the solid nodule, was not very good for the semi-solid nodule. But at the same time, AI also has a role in diffuse lung disease. We can use the CNN, this neural network technique, in a thoracic radiology, thoracic CT, for the diagnosis of staging of COPD or even for the ARDS. A specific study that done by Walsh et al. Showed an automated classification for the fibrotic lung disease with a database of around 1157 patients. And what they came to know that the accuracy was more than 73%. The similar study in the fibrotic patients was done with the Caliper software, which in which we use very specific thing like this approach consists to divide the lung into the numerous small patches with the same size and then classify them into the different ILD pattern. Even this study was found to be very significant as far as the AI is concerned. We all have seen, during COVID-19 that it causes significant impact on everybody's life, and specifically if we talk about the radiology, every radiology was in very hard work of pressure at that time. There are studies of AI related to the COVID-19, which was done for the X-ray imaging. And they also shown a significant, the performance, like the sensitivity of a 95% with the specificity of a 99% as far as the AI in X-ray of a COVID-19 was concerned. And One more study was done that is related to the CT scan, and even in then, the proposed model achieved about 95% of a specificity. So I would say this AI has a significant role in a radiologist or imaging, and the machine learning has already been part of everybody's life, specifically radiologist life. The multiple applications are currently being developed with a deep learning based approaches and will require a prospective clinical evaluation. We should also understand that radiologists can benefit from the workflow optimization and can gain performance for detection, characterization, and quantification tasks. And we should not worry from there, because the human validation remains as necessary as full automation for imaging tasks and cannot be considered at this time. So I would say the AI has a significant role in imaging, and these data, what I'm showing and what I read in last 2, 3, 4 days were amazing, and even I was very surprised to reading that. Thank you very much.
Thank you, Dr. Mantri. That was quite informative, and I think that is something which probably all of us are aware of, radiology. But there is something more to this. And how are we going to apply this all into our practices? It's all the buzzwords, all the tech is available to us, but how are we going to use it? So let's call upon our guest faculty, our guest speaker, Dr. Balu sir. And I request you to share your experience, what has been using AI in the actual real field. Balu sir, please take over.
Good evening, everyone, and I take this opportunity to thank Chess Council of India for giving me an opportunity to speak on a very interesting topic, AI applications in pulmonary medicine, current and future. I'll be sharing more of our experience of implementing an AI-based program in the community setting in the public sector. Just to give an idea on how machine learning works or AI works, it's basically training the computer, taking thousands of images, so that once we train the machine and we expose the image, it automatically identifies what is that image. Like, for example, you're seeing here, we have trained the machine to identify cat, and as soon as we put an image of cat, it correctly identifies that is a cat. So to do this, we need to have a lot of data which is fed into the machine, so that it becomes familiar with various alternatives which we come across in our day-to-day practice. As mentioned, I will be sharing about our own experience of using AI in the state of Karnataka with the program what we call as STAR, Screening for TB using AI at remote radiology facilities. This is a partnership between mainly between State TB Office, supported from India Health Fund grant through QRI, and USAID, KHPT, and APT. So to start with, we selected 5 districts in the state of Karnataka. The selection was based on why are we bringing AI into the public sector, mainly in the area of tuberculosis. And when we looked at districts, there were some districts where the diagnosis of TB was happening based on chest X-ray above the state average. The state average comes to around 12%, but there are districts which go as high as 35%. The numbers you're seeing 1, 2, 3, 4, 5 are the district. I have masked the district name, but this gives you an idea on how evidence-based approach was used to bring in an AI tool into the public health system. Now, there are various tools available for using AI for screening X-rays. There are automated modes. There are softwares which run on offline mode. But as we were looking at using an AI tool in the periphery, used to be by frontline staff, mainly the TB program staff, we felt using an app-based approach would be more appropriate. And as we were also looking at how well the AI picks up analog X-rays, we also need to remember all the AI softwares which are developed work very well with DICOM images. But this was an attempt to look at how we can bring AI to screen analog X-rays, which is very common as we move from district to periphery, and also more common in the public health system. Now this works very simple. What we did was we trained the NTEP staff, mainly the TBHV or the lab technician of the sites which we selected in these 5 districts. We took up to Taluka hospital level implementation. We didn't go up to CHC level because it was a pilot. This works on very simple philosophy. You can see it from the photo here. The TBHV or the assigned staff just puts the X-ray film on the view box, and he has to take a click of it using the QTrack app. Once he uploads the X-ray, the report will be generated. You're here just seeing a dashboard on how the report gets generated. And you can clearly see the AI has picked up some cases as presumptives, which gets highlighted in red color. Now, again, I want to just stress here, presumptive means it's not as per the definition of the program. As per the AI, it says this X-ray may have signs suggestive of TB. Now, once we move forward, we have also got access to the radiologist or the treating doctor there. He can access using the same app by using his username and password. He will get to know where is that particular lesion which is highlighted by the AI. We all need to remember here, AI never gives diagnosis. AI always suggests, is there a lesion which matches with what is told? That's all it does. And it is up to the treating physician there to confirm and validate, yes, this lesion is definitely there, and he can take it forward for further evaluation. The protocol we followed is whichever patients was triaged as TB presumptive by AI, it was also reviewed by the local doctor there, and all the TB presumptives by chest X-ray, we subjected them to CBNAT. See, one of the reasons we took this chest X-rays based screening is many of the patients visit these hospitals for various lung health reasons. So we felt it's a good opportunity for us to screen all the chest X-rays happening in these taluk or district hospitals, so that it acts as a triage and helps pick or improve the yield of TB cases in these sites. Now, you saw in the first picture what I showed, AI was supposed to identify what we train on. Like I trained the machine on cat, it is supposed to give an outcome as cat. But during our implementation, we also found that it's not only cat, we were also able to identify some other animals. I know, just to give an example, here it was supposed to identify cat, but we also used to get dog. This is just an example I am giving. What I mean to say here is the machine was trained to identify cat, but it turned out giving wrong interpretation. So we need to keep this in mind when we are using AI and try to understand what are the reasons. Now, these were some of the reasons which we elicited. I'll not go in detail as we were using an app-based approach. The way the photo was taken, the way the photo was uploaded, the quality of the image, and sometimes people used to use flashlights. These all causes artifacts in the photo what was uploaded into the AI, and AI can't differentiate between artifact and real thing. So it led to a lot of wrong interpretation of cases. So this we need to keep in mind. AI works well only when it is done as per the protocol. Similarly, some of the other things which impacted the results, why we couldn't get accurate results, also quality of the X-rays, how the X-rays were taken, how the X-rays were developed, they also had impact on the AI results. One of the things we also noticed was, well, although we were looking at tuberculosis, we also found there are so many cases which were picked up. Dr. Rajesh, who will be speaking after me, will be sharing his experience where we were able to find so many other diseases. From mainly, one of the rarest things we found out while doing this project was they were able to pick lung cancer cases, but we didn't know whether that was picked at the community level. So we felt there's a need to train the doctors working in these hospitals on basic chest x-rays. So we did one session as a pilot to see how it works. The whole idea is AI is just a tool. At the end of the day, the doctor has to confirm, yes, whatever the AI is saying is correct or not. And we also felt, although we have started with tuberculosis, it gives a good opportunity to explore the whole lung health. So this is what we have started as pilot, but we will continue it based on the learnings. To conclude, we all need to remember AI is any other tool like we use for TB. It may be sputum, it may be CBNAT, it may be FNAC. It is just a screening tool. What I always call is AI is an aid for us to reach to diagnosis. We can't entirely rely on AI because the doctor is the key person who has to validate, yes, this science as picked by AI is also suggestive of TB or other lung health conditions. We need to also clinically correlate with many other factors before putting the patient on treatment. So I always feel AI is just an aid and it's a triaging tool at best. And AI definitely will help us to look and find cases mainly in the peripheral areas, particularly in the program. Thank you.
Thank you, Balu sir. It is very interesting and very, I would say, fascinating to know the things that are happening in the periphery, and it's good to see that public sector is taking up the lead in AI. And I think it's time we have a discussion. So let's start the ball rolling. My first question, I want now the things to be discussed. Now we have done the lectures. Let's start the discussion. Dr. Anil, my first question is to you. What are the modalities of AI that can be used in respiratory diseases? We spoke about etiology, but can you give us a brief overview of all the modalities that you are aware of?
At the outset, good evening, friends. And I would like to thank the CCI for roping me into this uncharted water. Mehul, this is mostly a hypothetical situation right now, but certainly that my speakers have done a good job, the previous speakers, and they have given some information about what kind of modalities are right now happening. I would like to say that this is not a new science. Way back some 2 decades ago, say from 1980s itself, AI has been into the field of pulmonology. For example, our basic instrument, the pulmonary function, what we do is already based on this algorithm-based concept, wherein a lot of information and data is always analyzed and they give you a report. So to be brief, I will tell you the important modalities right now, whatever we are using, most of them are not available in India. As such, the radiology field is the one which is using the AI modality. But I would say there are few conditions in pulmonology which use these AI modalities. First of all would be the COPD, that's the obstructive lung diseases, where we have got 2 or 3 different AI algorithms. One is the lung density analysis software, and we have a lung Q analysis software. These kind of algorithms generally use this 3D lung segmentational systems, or they do a density evaluation, or they do a volumetric analysis in finding out the obstructive lung diseases and trying to give us a prediction. And there are many softwares in such kind of an AI for COPD diseases where you can predict the mortality depending on, and you need to just give some input data such as the FE1 in the first second, the age, and the 6-minute walk test, and they can accurately predict it. Coming to asthma also, we have got many AI algorithms which can easily predict the steroid responsive kind of a phenotypes and the steroid non-responsive phenotypes. When you come to the second disorders, it is the interstitial lung disorders where we have got some algorithms. One is the lung print discovery algorithm, and the other is the lung texture algorithms, which always allow you to diagnose the interstitial lung diseases in a proper way. And with these algorithms, we can make a clear-cut differentiation between the various types of interstitial diseases like the NSIP, the UIP, the chronic persistent pneumonitis, and other things. Coming to the other modality is your pulmonary infections, where you can use your AI algorithms to detect the TB, detect the pneumonias, and detect COVID-19 infections as well. In these kind of situations in pulmonary infections, we have a IcoLung kind of an algorithm software. We have a infrared CT softwares which can easily detect the pneumonias. They can even differentiate between COVID and the normal community-acquired pneumonias. And the most important part would be the lung nodules and the malignancies. This is one important part where a lot of work has been done. Here you have got the radiomimic AI algorithms. You have got a single CT lung algorithms, as Dr. Bhagwan and Dr. Rajesh and all the other speakers said before that. We can clearly identify the lung nodules in the asymptomatic population as well. So we have got some temporal softwares and everything. So I would like to reiterate once again that chronic obstructive pulmonary diseases, interstitial lung diseases, identification of pulmonary infections, to differentiate between a CAP and a COVID, and to even detection of tiniest of lung nodules, we can use various AI modalities.
Thank you, Dr. Anil. I think the simplest form of AI we use is probably our PFT machines, which give us a computerized diagnosis. When we just give them a loop, probably, and that's the summary of it, that it can be wrong. Nobody looks at the loops. So let's keep the discussion going. Now let's come to Dr. Devi Jyoti. Everybody's speaking about AI in ILDs. What about airway diseases? What is the role, or probably where do we land using artificial intelligence in airway disorders?
Yeah. Hi, good evening, everyone. AI is very much beneficial in diagnosing and management of airway diseases also. Like we have already discussed about the radiology in various diseases, how AI helps us. So if we take COPD, there are many algorithms which take the lung density analysis to diagnose emphysema, to quantify emphysema, and also there are many studies which have found that they have a correlation with gold stages also. So, and also in asthma, according to the rim of the small airway width, there can be a prognostication about the exacerbation and about the severity of the asthma. As you rightly already said, if we take PFT is the simplest form of AI we use, and there have been many studies where it has been shown that AI is at par or even better than pulmonologists in diagnosing diseases according to spirometry, and especially when a spirometry or a PFT report is being read by non-pulmonologists or in peripheral areas, especially in remote areas where you don't have specialists. It is a very important tool. Like Dr. Anil has already told, classification or clusterification of asthma patient, like are they steroid sensitive, are they steroid resistant, because in asthma treatment we sometimes do overuse steroids. So according to AI algorithms, we can find which subset of your patients are steroid sensitive. Like in a very good study, it has been shown that late onset asthma patients with high eosinophil count, with nasal polyposis, with severe obstruction, they fall into the steroid sensitive group. So steroid should be used at the onset and for a longer duration in such patients. Also, there are many AI algorithms which can use respiratory sounds to diagnose and to learn about the exacerbation of obstructive airway diseases. And mind you all that these don't use rhonchi or wheezing. These use other breath sounds so that early management of exacerbations can be done. These are a few examples where AI can be used in obstructive airway diseases.
Yeah, also, if I may add, there was a recent study published just now in September 2022, which AI was using to differentiate asthma from COPD. Sometimes, and asthma COPD overlap for that matter. Even though the term is in debate, we are teaching AI to learn the debate also. So that's something new, and the accuracy was around 68%. So that's not bad. Even sometimes as physicians, we get confused how to diagnose asthma versus COPD. But AI could diagnose up to the tune of 68%. That's pretty good. So I feel that's something which we should look for in the future. Now, let's take the questions from the audience also. And this question I will come to, this question has been asked by Dr. Kunal Waghela. What is CAD? So Dr. Mantri, let's you only answer it. What is CAD? And second question to you is, what have you, and we have read about the theory. What have you seen practically been used AI in your area or in pulmonology currently available in India?
Right. So first, I'll just, I already explained about the CAD. CAD is a technique. I mean, it's a simple computer-aided diagnostic technique, computer-aided diagnosis for detection of any, method. CAD specifically is to be also. AI has a really significant role in imaging, not only in the X-ray as well as in the CT scan. Even though the CT scan, because it has a and a lot of segmentation is required. So the outcome of the CT scan is not. I was surprised to see the result, like at the PHC level, and really significantly beneficial for every people, because like even at the district level center, the people are not able to diagnose these simple pneumonia, pneumothorax, the pleural effusion, and this basic disease. At least we can easily diagnose with this AI, and nothing measure. I mean, we just need to understand what it is doing. Whatever we are feeding, it is coming. Like we just need to feed that very common diseases to segmentation or for the storage form, and then the result is coming. So for these basic, the workup like the PHC and CHC centers, if we are diagnosing these X-rays with this efficiency, then it is really playing a very great role. And maybe in near future, the CT scans and other things will also get, perhaps further better.
Yeah, so I totally agree with you. Actually, what Balu sir has presented, actually, I've seen that software. I've been working with the public-private engagement in Mumbai for tuberculosis, and we saw that program. So it has a lot of rough edges, but it can be used. And as you said, all these tools are mainly to make us reach the periphery. Probably sitting in a metro like Mumbai, Delhi, Chennai, maybe we not be useful that much, but at least in the periphery or in a pandemic situation, it might be a great help. But let's say, Dr. Dinesh, let me get you in the discussion. Let's say the ILD CT scan has shown that there is an ILD, and we have Dr. Jankaria here, beautiful center. He gives us caliper numbers, and he says that there is a progression of fibrosis by X percentage. Dr. Dinesh, would that make a difference to your treatment? I mean, if you see a radiology showing progression by X percentage, will it make a difference to your treatment? Dr. Dinesh? I think we have lost Dr. Dinesh. So let me, does anybody wants to take up this question, or?
I think you are the best person because you are working in that where you are able to get the reports in that way. We don't get our CT scan reports or X-ray reports that way.
So I'm not that lucky to get every CT reported by Dr. Bhavin Jankaria, but what I see is when I see a COPD progression or I see an ILD progression, I see the patient in toto. I see the patient's clinical symptoms. I see the symptom score that we do. Actually, we use a lot of AI by natural methods. We have a lot of scoring systems, the asthma scoring systems, or the ILD progression score that we see, St. George respiratory questionnaire. These are basically AIs, nothing else. So we see the patient as a whole. We see what has been the PFT, which has worsened. You see the 6-minute walk test, and probably add to the radiology and maybe a composite score. If I have an AI which can give me a composite score, probably that will help me a lot. Otherwise, just having the CT scan or a CT scan telling me there's a progression of by 5% or fibrosis worsening by 10%, I don't think that would be very helpful. So I think here, Dr. Dinesh, can you hear me? I think he's here. Okay, so the point is that AI does help, but you have to use a clinical judgment. Just don't rely on the CT scan or the AI induced, like Balu sir said, something was shown as to be presumptive tuberculosis. You don't start treatment for that patient. You have to take the clinical context in it, but it does help. Sometimes, we are good at reading CT scans. Maybe the physicians who are sitting in the periphery may not be. So that may be useful for them. So now coming to actual clinical experience, what people are having, I'd like to bring in Dr. Rajesh here. Dr. Rajesh, you're there? Dr. Balu, Dr. Balu mentioned that you were there with him. So can you share your experience of using AI in the periphery?
Yes, so I would like to continue from where he left. So this is all about what happens after AI has been given to the people in the periphery. So as he showed few X-rays, all those X-rays which I was asked to go through, they were all CPNAT negative. So now there was the person who is actually facing the patient will be in great dilemma. The patient is having symptoms with the CPNAT, the most sensitive test is negative, what to do. So when I went through the X-rays, there were basically three patterns I could recognize. One was active lesions interpersed with inactive lesions. For a pulmonologist, these are easy, but for a non-pulmonologist from any other fraternity, this would be difficult to pick the active lesions interpersed with inactive or healed lesions. So he'll be in a great confusion whether to pursue this ahead or to leave it there. And the second one was the lesions which would have low bacillary load. So we all know cavities have highest bacillary load, but these nodules will have very minimal load. So again, and this, the treatment algorithm, the recent one, has been, there is a change. Now, there was a practice earlier that somebody has feature suggestive of TB, sputum AFB is negative, you treat with antibiotics, then see what happens. Now, after the introduction of CBNAT, that treating with antibiotics has been taken off. Now, after AFB, now the next step is CBNAT. So we were also looking to save some unnecessary use of CBNAT cartridges. So if there are X-rays which are all having healed lesions, which was not properly picked by AI because of all the procedural difficulties as pointed out by Dr. Balu, including the flash, so few cartridges would have been saved. That was the second pattern. Third were outright malignancies, where we all know that eccentric cavitation goes more in favor of malignancy, but for a non-pulmonologist, it will be a bit difficult. So all cavities would look alike, and we have seen enough cases where cavitating malignancies have been treated for tuberculosis for months together. So these are three basic patterns which I could identify. So that way we felt there is a need for hand-holding the frontline healthcare personnel who are actually facing the patient, so as to what to do next. And there emerged this concept of lung health. So if it is not TB, what it is? Malignancy, we saw few one or two silicosis cases also. So that way we would, it was very enthralling experience to see how AI can help in actual screening and reducing the burden of the people in periphery. And then we also felt that there is a need for human touch, the hand-holding, after what inputs have been given by the AI.
Yeah, that I agree. I mean, hand-holding is very necessary for AI. I mean, Dr. Tridip Chatterjee from Mumbai has commented that progressive fibrosing ILD is not defined by AI worsening. I agree with you, sir. I was just giving an example that if I get such a report, what would I do with it? Does that have any meaning, clinical significance? We just don't rely on the reports which show that. So there are a few questions on, I can see in the chat box on treatment. We shall take them when the treatment thing is going on. So coming to Balu sir, and I think this question which I've got from Dr. Kulkarni will be addressed to you also. So Balu sir, I mean, how can tuberculosis overall help us fight the menace of tuberculosis in the country? And the second question also to you, sir, which has come in the chat box, that AI data is very variable depending on the software. So how you harmonize that option?
Yeah, thank you, Dr. Mehul. I think one of the things we need to appreciate Government of India is TB program is the first program which has taken AI into large scale. When we look at all the other programs happening in India, it is only the TB program starting from CTD which has shown very keen interest. As of now, CTD is working closely with state government and partners. One of the things which last year they started working and they have collected data is, can we predict tuberculosis or suspect tuberculosis based on cough sounds? This was done in COVID also, cough patterns and identifying whether it could be due to TB. So that validation is already happening in the field. Second most important thing, which again they have started in a few states, is we are worried about drug resistance TB. Now, one of the main reasons for drug resistance TB is people drop out of treatment, basic treatment. So now they are developing AI tools which can predict which are the patients who can drop out, so that you can focus your efforts more towards these patients and ensure they are put into treatment adherence. So in addition, CTD itself is also, some of the state governments are already working with developing AI. I do believe some states have already started looking at CT was mentioned. So when you look at CT, some of the states have already developed their own AI softwares to look at CT scans. Now, coming out of the government setup, there are a lot of organizations which are working towards TB program per se. One of the things which is currently happening, we don't know how the results are, is how do we predict drug resistance TB using AI through genomes. This is very well documented in Western world, but some attempt is being made in India. So when we look at as a whole, I do think AI per se, HDI has taken it up very well, and also I believe we need to look at periphery where AI can help. So with validation, and we need to see how well it works in the field, it will definitely help India look at ending TB by 2025. So this is in relation to the first question. I think the second question was on, I do believe there are different
softwares,
soft validations. How do we come to conclusion? I totally agree with the question Dr. Kulkarni has asked. We need to be careful in choosing the AI tool. There are so many people who come to us saying we have developed an AI tool. So that may take us away, right? So we need to look at how it was developed. What was the data set which was used? Because many a times the biggest problem we are facing in AI is everyone is developing an AI tool just by doing 100 sets, 200 sets. So please look at, are these endorsed by WHO or Stop TB Partnership if you are looking at using it for TB. The second thing is we need to look at what kind of recommendations the software company gives. Because as I already told, most AI tools work well in DICOM. That is how they have been trained on. And again, yes, there are a lot of differences. We have used many softwares on TB. Yes, that is part of the gamble which we play. It's something like what we as a doctors also. One doctor may agree, some doctors may not agree. So yeah, AI, as I told you, is just an aid. At the end of the day, we need to build capacity of the doctors, take it forward.
Yeah. So, I mean, AI, I mean, the buzzword, I mean, one question has come again from Dr. Tridip that whether it can diagnose miliary tuberculosis where sputum and ball may be negative. So maybe we can come to a differential diagnosis. I don't think we can be confident enough with AI giving you a confident diagnosis of tuberculosis, like miliary tuberculosis. I would go certainly for a biopsy. And the second question from Dr. Anupama, she's saying, is AI in pulmonology useful for non-pulmonologists or in rural settings? How about for pulmonologists? I think we are going to cover that question. We have an interesting take on what is going to be our role in this. Let's keep the ball rolling. I mean, the next question I would like to ask Dr. Devi Jyoti. I mean, we've gone through a bad phase of COVID pandemic, and Dr. Mantri spoke about utility of CT radiology in COVID. So how would AI fit in a pandemic situation? What are the uses? Maybe any specific use you can think of?
Yeah, actually, AI has been very useful in recent pandemics, and what we need during a pandemic, early diagnosis and check of spread, right? So early warning signs or early detection is very, very important. Like an algorithm was there, Blue Dot, which was also used during Zika virus outbreak in South Florida in 2016. So what it did, it skimmed the foreign news and announcements, and it just gave early warning signs even before, even almost 10 to 15 days before WHO announced about COVID outbreak. Also, it could tell us about the spread or the contact. It helped in contact tracing, all by the data by the airport authorities. So it could assimilate all the data and give early signs. Also, many AI algorithms help to screen symptomatic patients in a crowd and help to early isolation of those patients. Again, very, very important. We all were mesmerized when in China, AI robots were used to deliver medicines for that contactless delivery, also various things, even for entertainment of the patients during the quarantine phase or say isolation phase. There is Google's DeepMind, if I'm not wrong, DeepMind algorithm, which studies the protein structure of the virus, and it predicted it and expedited the vaccine formulation, which would have taken like months if we would have been without the help of AI. So I think AI is very much helpful, especially in recent pandemic.
Okay. So mainly, I think probably, triaging was probably the first thing that it came into our mind, and then probably getting help in vaccine development and maybe finding out where to focus our energies on. So, Dr. Dinesh, I would like to ask you the next question. If we use AI a lot in imaging, but as pulmonologists, we are very happy and very focused on our interventions. Do you see any role of AI in interventions, pulmonary interventions that we do? I think you're on mute, Dr. Dinesh.
Yeah. Now, can you hear me?
Yeah,
now?
I can hear you. Yeah.
Sorry, there are a lot of glitches. Good evening, everyone. Yes, in the recent past, we've seen how the AI helps us in the recent diagnosis and early diagnosis, and getting ourselves into the early warning signs and diagnosis and treating them. In the case of intervention pulmonologies, at least we'll be able to see and direct ourselves as to where and how to take up the biopsy or where, according to the algorithms. I think Dr. Balu and Dr. Anil have already focused and spoken about the algorithms as such. So there's a specific cell lineage identification in carcinogenesis, which can guide us in the diagnostic approach and the malignancies by doing specific biopsies, even in the deep-seated thing where we can go in. So the AI will definitely help us, in predicting the outcome based on the clinical scores. And artificial definitely need to have laboratory data, but again, we will be able to do a lot of justice by doing the possible outcomes, by doing a proper biopsies, and also guiding us. Of course, the nanotechnology is there to stay as such. I think this all started with, I met a professor in the US about 10 years back. He was talking about nanotechnology that time. I think it is the third conference of the APSR. And, yeah, it has come a long way. I'm sure it is developing in the leaps and bounds, and it should definitely help us.
Yeah, so I feel, AI has a role. We already have navigational bronchoscopy, which is helping us, go through deep. We put it in the lung vision software or probably whatever software that is going to develop in future. You put the CT images, you put the bronchoscopic images, and they can take you to the peripheral nodule that we are doing. And probably it also, there is a lot of data now coming up for rapid on-site evaluation. Again, it's all about images. As Balu sir showed an image of cat, you train the computer to identify the image of cat. You train the computer to identify malignant, non-malignant lesion, maybe adequate or inadequate tissue. The data has been, and people have studied whether the biopsies that you take, the on-site evaluation of the EBUS specimen that you take, whether it was adequate or inadequate. And AI was able to match at least 70 to 80% of the times, at least the adequate and inadequate tissue. Then it can be processed further by the pathologist who is there. Second was there is a lot of interest on robot-assisted bronchoscopy. I mean, first thing was done on a Monarch equipment, and probably there is one field which sounds very fascinating, but probably I don't think we're going to reach there soon. So we have one question here from Dr. Kulkarni again, that AI-derived diagnosis will eliminate biopsy or bacteriological culture? Maybe not. Maybe not. It might probably help us to tell you where to take the biopsy from or where to take the specimen from. Yes, there is a lot of interest, or there are certain studies, a couple of studies which are read, which said, okay, maybe for diagnosing, malignancies, you can use AI for maybe the staging, but I don't think tissue is the main thing. Anyway, in bacteriological culture, I would not rely that if this cavity is looking, whether it is looking tubercular or whether it is looking a fungal cavity, AI telling me would not be enough. I would definitely need a bacteriological or a biopsy specimen if I'm looking at malignancy or if I'm looking at any such thing. So probably that will not be replaced, but yes, it will tell you where to focus your energies on. Now, coming to the important, yes, sir.
Where it can direct us. It can
Direct us, yeah.
And tell us where to take the specimen, where we get an adequate specimen.
Yeah,
with,
exactly.
Least complications as such.
Least complication, least trauma. But I think it won't be replacing us anytime soon. So coming to the most important question, I mean, what is the scope of pulmonologist in AI? I mean, this has been asked, and Dr. Anil, can you come in? What do we do? AI is there. What is our role?
Yeah, Mehul, as you said before, the role of AI itself is divided into two parts. One is your virtual and the other is your physical. Coming to the physical, I would say it's more of a precision medicine. You already have your precision medicine clinics now. The basic role of AI here is to have a early presumptive diagnosis, to get an early diagnosis to aid in the proper treatment of the patients. So the first role itself of AI would be in the precision medicine. We have our ECG machines, we have our spirometry PFT machines where the AI software always helps you a lot. Coming to the role of pulmonologist, as I said, there are some pulmonologists in the rural areas who have a very minimal access to the imaging facilities or the diagnostic facilities. I think we are the only subset of doctors who don't rely on the radiological reports given by any other departments, right? So we always make our own diagnosis. But certainly in a subset of, in some rural areas and some other areas where you don't have a proper facility, certainly these AI-based algorithms can help you in making a proper diagnosis. And moreover, we pulmonologists, this subset of, we can create a this data set where we can provide it to the different organizations, because we have data on ILD, we have a lot of CT scans which we store for our own referral purposes. Then we have a lot of experience on COVID-19, reading the CTs and everything. So I certainly feel as a pulmonologist, we should be a part of this AI making algorithm process. We all should get involved into this. Moreover, into our clinics, we have to incorporate this AI no later or sooner, because this is certainly going to help us in diagnosing the overlapping conditions in asthma, COPD. Sometimes in ILDs, you might be confused with NSIP and UIPs and all. So maybe we can make use of this AI algorithm to come to a presumptive, clear-cut precision diagnosis.
Yeah, so I mean, to add to that, I mean, the specific question asked is what is going to be our role? I mean, I think we can be mentors to the AI. AI is mentoring probably the non-pulmonologist or people sitting in the periphery, helping them at least get a guidance where to send the patient, whether this is malignant, non-malignant, suspect TB, non-suspect TB. I think as pulmonologists, our role is going to be as mentors to the AI softwares. In fact, if I can be bold enough to say that if, we have so many pulmonologists in the CCI group per se, in all the groups combined, if we just take all the X-rays and the CT scans that we see, we can have a huge database of all the X-rays and the CT scans from CCI itself, and we'll be contributing to the major chunk of kind of database that the AI needs to learn from. So that is something to probably think about. So let's think about the new thing. We've come to diagnosis, we have seen the X-rays, we have seen the interventions, but does AI have any role in therapeutics? Can it help? And Dr. Mantri, may I ask you, what if I say AI needs to help me in therapeutics, is there any role?
So if we talk about the role of AI,
from the diagnosis to the the collection of the data to making further precision in a diagnosis to the treatment. AI has a role in everywhere. About the treatment part on a therapeutics, I would say if we talk about the ICU part, like Dr. Devi Jyoti already said, that during the COVID-19, we already seen the AI had significant role in, the treatment part. Treatment means which patient will go on a ventilator, which patient will not go on a ventilator. This AI significantly, reproduced, even though like the COVID things never happened because the COVID was totally different disease. But at the same time, if you talk about the ICU part, antimicrobial resistance is also, helped by the AI in many patients. So the many things are developing. Even if you talk about the ICU, the AI has a role in predicting the mortality also. So we just need to, like what we are discussing, that AI is having a role everywhere, but we need to define like which criteria we need to pull and what are the things that we need to take from the AI. Like if the X-ray is showing by the AI a tuberculosis, that does not directly mean that it is a tuberculosis only. I mean, any cavity would show through the AI like tuberculosis, but even if it is a cavity of a cancer, it could be the false positive for the, the tuberculosis. So we need to take a support from AI. And, certainly this has a definite role in therapeutics also.
So I have one question from the audience. Dr. Romesh Sharma from Vadodara asked role of AI in treatment in children. So if I have to answer this, I think there is actually one good study, I would say overall, since you asked only in children, about diarrhea caused by rotavirus.
Yes.
So AI did help to combat antibiotic resistance or misuse by predicting which probably look like a viral diarrhea and which would look like a bacterial diarrhea. So there was some study from Florida which suggested that probably this criteria fits into a viral subset till you get all the other results. It's like feeding your own algorithm. What we have been taught in textbooks, which we probably may not remember the each criteria. We go to Wells criteria, we go to all the other criteria for dietary embolism. You put it in the computer, it will give you the data. That is what AI is helping us do. So probably that is there. And to add to what Dr. Mantri said, currently, I mean, I just read it today. I mean, for me, it was something new that AI is helping us make new regimens for tuberculosis. I mean, if I have 5 new drugs coming up for TB and treatment has to be given for a period of say 20 months or 18 months, I cannot be doing trial and error and studies every time to come to get this is the best regimen to be given in these subsets of patients. So there is an AI helping. There's a study published recently in September this year only, which is looking into a lot of combinations of medicines which can predict which will work best in which subset of patients. So an exciting time.
Since we are talking about this antimicrobial resistance, AI is also helping to discover a new molecules, new drug molecule. So
So it is part of therapeutics. That is part of therapeutics. And probably, as you said, it can help predict which patient will go on an invasive ventilation. So that could be possibly something which can be there in future for us. So this is
some students are working on it in IIT, if I'm not wrong. They're working on that aspect, including looking at the carbon dioxide and all the other scores. Which patient can be healed out faster. I think there's a study which is going on at present.
Yeah, so all these things, sir, as Dr. Anupama has asked, do we pulmonologists undergo training program as trainers in simulation? Exactly, that's what everybody of us is doing. We are feeding the software. Let us all be trainers and carry this question forward, Dr. Balu. Since everybody is asking, is there any course or a field opening for, say, young pulmonologists in AI? How can they explore AI as a career prospect? Is there something like that which probably you're aware of?
I'm not sure whether people want to get into programming, which is not our forte. But as you clearly mentioned, I see huge role for all of you to play in the mentorship, because when we look at the way we are rolling out now for the private sector in Bangalore, in fact, we have started it. Some of the senior pulmonologists are mentoring, the basic MBBS doctors. I think that is one area where I see you people can play a big role. Like some difficult X-ray AI has picked up can be shared with you for your consultation or referral. The second thing, I think, as you clearly mentioned, I would be more interested to look at CCI as so much data other than X-rays and CT scans. you have a lot of other patient data. I think that is where your team can play a role in predicting, like what they did in COVID. Maybe you have huge baseline data, maybe computerized in many clinics. I think, yeah, you people can collaborate with some startup or somewhere and come out with prediction tools, which will be very useful at periphery. Predict, refer, used by ASHA workers or used by medical officers in PHC, so that it helps reduce, you must have seen so many problems of cases getting referred badly to you, right? So yeah, CCI can look at definitely using the data what you have got and develop your own some kind of prediction tools. Yeah.
Yeah. So I feel it's time. We had sleep medicine, and probably now AI can be used as probably a subset of subspecialty of probably pulmonary medicine. And as we all see our own scans, we see our old X-rays, we see our own prediction tools. We use it a lot in ICUs. I think that would be a good area to explore if somebody is interested. So coming to one hot topic, lung cancer. Once we see tuberculosis, yes and no. We see lung cancer. Our diagnosis becoming difficult. We don't have a screening program in our country. So, Dr. Rajesh, what would you place? I mean, AI. I mean, how AI will help you in lung cancer? What do you think?
Right from the beginning, where we think the person at risk, we should screen him. We already know the role of low-dose CT, LDCT. Now, as Dr. Mantri clearly mentioned, LDCT algorithms are almost based on AI. But now people have gone even further, because some outputs of LDCT are like indeterminate nodule. Say 6 to 12 millimeter nodule is 4 to 12 millimeter nodule is designated as an indeterminate nodule. Now researchers have looked at those nodules and predicted almost to a certainty of 86 to 90% that in future, which of these nodules will become a definite malignancy. So that is actually mind blowing. And there comes one more thing, that part solid, part ground glass nodules. Again, we have same difficulty as to we are sitting on the fence. There have been papers published in as early as 2018 that this particular nodule, they will look at around 23, 24 different characteristics, and they say, okay, this may progress to a real cancer, full-blown cancer, and to the extent of 86 to 90%, they have been accurate. From there, one of the participants has asked, will AI obviate the need for biopsy? The yelling answer is yes. There have been publications in last 2 years where the AI has looked at the CT images and it has told which histological subtype it could belong to. And again, all area under curves for this have been above 86 to 90%. Not only that, after a biopsy is taken, there is something called as WSI, whole slide imaging, where the pathologist has to screen from one end to another and then assimilate the data in his mind. There is something called as whole slide imaging, where this AI comes into picture. This whole slide imaging, which is the histological picture, combined with the CT picture, can give rise to, it can almost substitute the molecular studies. They have gone up to that accuracy. And there is a paper published in Lancet, May 2022, where they have studied 18,000 patients across the continent, across the globe. Some in China, half of the population in China, half of the population in US. This is because we all know EGFR status. We Asians do have a lot of EGFR mutations. So they have to negate the bias. They have included US data also, Chinese data also, some retrospective, some prospective. And they have not only looked at the tumor. All these days we used to look at the tumor. They have looked at the whole lung imaging. And they have shown that whole lung characteristics, when taken into account, can accurately predict the EGFR mutation status also. So it's there, it's knocking at our doors. It's for us to see how we adapt to it. As far as KRAS is and ALK is concerned, there is the slight less sensitivity, but for EGFR, there is mind-blowing sensitivity. Not only that, AI has been successful in predicting, even after surgery, for early stage cancer, which patient is going to recur in the future. And then not only for EGFR, for radiotherapy, for chemotherapy, everything AI has been successful in predict. Maybe these are small studies. AI has been successful in predicting who will respond, who will not. Even for immunotherapy, AI has been successful in predicting who will respond, who will not. And one of the things which was very fascinating was because there is no other way for us to look at the whole lung data. We cannot take biopsy from each lobe and all. We just take from the tumor. But this thing has done it. It has, in addition to tumor specific data, it has studied whole lung data, like how the vasculature is progressing towards the tumor, how the pleural retraction is happening. And they have used some 25 other filters. They call it as layers. And to a certainty of 90%, they have come up with the result that 18,000 patients across the globe who is having EGFR mutation. Not only that, we all know EGFR TKIs, people develop resistance after, say, median 18 months. Gefitinib will not be useful, we'll have to go for osimertinib and all. This AI has predicted which subset will develop resistance in the future also. So yeah, it is there, definitely. So it is for us to adapt to it.
So I don't think how confident I will be just handing over the scan to the AI and putting the patient on chemo, starting maybe sending the patient for surgery.
One of the main drawbacks of this AI, which is accepted by all these papers, is that there is lack of reproducibility. There are many studies are in small subset, as Balu sir was telling, 100 patients, 200 patients. But even the large scale studies, they in the end write that there is a limitation of lack of reproducibility that is mainly based on different modalities of image acquisition. One of the participants had asked that AI, there are different softwares. So now the effort is going on to standardize everything. Like we have one GINA guideline or GOLD guideline. They are trying to standardize the image acquisition process and the image processing process, the algorithms, so that this reproducibility part is taken care of. So in future, yeah, there is definitely a human touch is needed. There is no denying of that fact because it is our brainchild. But it is there. It is there definitely. They even claim that at the same cost of doing a CT, you can get the information of molecular footprint. So that is actually amazing. There is no additional cost other than doing CT.
I think such a study should be validated across all type of tumors. Probably we can test out.
This was just published in May 2022.
It is exciting time. Like Dr. Anubama is asking, like AI in pulmonology has become an important question in the MD Chess University exam in the recent years because it is the most developing field. It's probably like telling you self-driving cars. I saw a video of self-driving car where the computer has information of maybe millions of miles. Every computer gets the same millions of miles ka data, the experience, and then the car drives. So much so that this webinar itself has produced more than 750 logins. I mean, this has generated interest. I mean, this is something which is unique. Everybody wants to know about it, but we should know where to use it. It's like telling that we have a bronchoscope, a person, a pulmonologist who joins pulmonology would want to do first a bronchoscopy. I want to do my MD resident, my junior said, "Mujhe bronchoscopy seekhna hai." But when I tell them, boss, you should know when not to use it, how to use it, where to use it. That is more important than using it per se. So probably AI is something which we will be using. As you said, probably we can have prediction models. This is probably malignancy. This is possibly EGFR positive to the right histopath. But we need to validate it by doing further tests, by helping us guide what biopsy to take, maybe do an on-site evaluation, and maybe predicting the treatment outcomes. So this has been, something which moderating this session gave me a lot of insight. I had to read a lot. I'm sure all of you had to read a lot of recent data coming up, something which we also learned a lot. And I would like to have now, maybe some closing words or wish list for AI from everyone. So we can start with anyone, Dr. Anil. What is your wish list or maybe the closing comments for this AI in pulmonology?
Yeah, Mehul, as you said, this is quite a new topic. And I would say, see, now we are going to a world where in the future, everyone is going to say, hey, Siri, what is the diagnosis? That is the world what we are looking to right now. So certainly, rather than taking this AI as a competition or whatever it is, let us all take it as a complementing tool. Let us all use this AI for a better diagnosis of the diseases. Let us reduce the economic burden for the patients and all. No? So we can certainly use this. Let us complement with each other. And I don't think we should compete. We should complement. And everyone, no sooner let everyone has to get into this game right now. And we have to learn this AI for the betterment of the patient.
Yeah, so I agree. Dr. Dinesh, you want to add something, sir?
Yeah.
Your
Yeah, see, AI is definitely there to stay. It's just that how we are going to use it, when we are going to use it, and that actually defines us. It is our brainchild, yes, but again, if at all we entirely depend on it, it is not going to be a safe method, is what I feel. Of course, in the next 5 to 10 years, maybe it is going to develop more, given the algorithms which are coming out, and we'll have to still develop on that. But I still feel we have to also rely on the biopsies as such. Right? We should rely on where to direct, where to do it. Of course, there are other algorithms. Once those are developed, we should be there. But of course, yes, it's still a learning process and a long way to go. We're definitely not going to be eliminated from that, not very soon.
Dr. Devi Jyoti, your closing words.
If we are thinking if AI will replace us, the answer is simply no. But yes, it will help us a lot, especially during COVID and times. It took off the workload from many radiologists, like when they could predict the severity of the CT picture. So we all use the scoring system, right? We all use it. Obviously, you have to take into account the clinical picture also, where we as doctors come into play. So I think Balu sir is the best person to answer this about the limitation. Yeah.
So I'm reserving Balu sir's comments as last, probably at the bottom line. Dr. Mantri, your closing thoughts.
So in this, AI webinar, I learned a lot. Like everybody, I think we learned a lot. I mean, AI is doing too many things. This I was not aware. I think nobody was aware that this many things are happening in a world of the artificial intelligence, and so many things are happening. But at the same time, I mean, I'm not comfortable at this moment, at least, like doing everything through the AI. Definitely the human touch is required, the clinical things are required, but certainly if this AI is doing these so many things, so it is helping us out. I would expect in future something that would come that help in the diagnosing the ILD that is very confusing. So let's see. I mean, in future probably this would also be there, but at least for now, I would say AI is helping us. It's not replacing.
Dr. Rajesh.
Yeah, so all said and done, let us not lose human touch. Finally, we all know that famous movie by Rajinikanth, Robot, where all absurd things it does. So once the human touch is lost, because how much our AI algorithms pour in, there is no replacement for the joy which we have discussing with our colleagues or a cup of coffee in hospital canteen or somewhere. So tea shop or somewhere. So it cannot replace our that joy is unmatchable. So whatever AI comes, it will come definitely, but let us not lose the human touch.
And Balu sir.
Yeah, my wish list is start using AI. There's huge resistance from doctors whenever we take it, more so in the medical colleges. I feel we should start embracing AI. The basic reason is as more and more doctors, more so in medical colleges, start using it, we know its limitations. We can definitely fine-tune the software, we can fine-tune the program, because we all need to remember AI is developed by program managers with little inputs from doctors. Now, my wish list is, yes, it's good, whatever AI is available. We need to start using it. Over a period of time, it will get better. Yeah, that's it.
So I would like to summarize this by saying, there was a song in the famous movie, Teri Jeet, Teri Haar, Meri Haar. It's not that with AI. AI is more of it's good as an assistant. As Dr. Anil said, hey Siri, what is the diagnosis? So Siri as an assistant is good, but sometimes it does not open up the calendar when you tell her to. So we have to do that physically. So let's keep the focus on diagnosing our own patients. Let us be mentors. Let pulmonologists be the mentors for AI, because the AI currently is focused mainly on radiology and pathology, and we as pulmonologists can play a central role in that. Let it be a good assistant. It is a very bad master. So with that, I would like to thank all my speakers. I would like to thank the CCI team for giving me this opportunity. And I thank to all the people who have logged in, more than 750 people who have logged in. And thank you, Krishna sir and Dr. Narayan Pradeep, Dr. Ashish Dubey, for giving us the opportunity to speak on this platform on this new topic. I hope we've answered few of your questions and have some developed some interest in AI for all of you. Thank you.
Thank you all.
Thank you.
Thank you.